Hello, folks. I'm going to give about 30 more seconds for folks to get on. You know, Dr. Maldonado is just joining too from her
Hi.
many obligations today. Hi, Bonnie.
Hi. Lots of interesting news from the FDA today.
Oh, good. Well, we're looking forward to hearing all about it. Why don't we get started? Hello, everybody, and my name is Alan Schroeder. I'm the co-chair of this weekly seminar series, along with Dr. Rajni Matthew, who's actually going to be one of our panelists today. We are skipping the evidence trainee quick hit today because there is so much to talk about. But as usual, we will quickly review upcoming sessions. We are off for the rest of 2020. And we'll resume 2021 by focusing on another organ system. We just focused on the heart. And on January 7th, we have a whole array of pediatric neurologists who will be talking about what we know in terms of the impact of COVID on the nervous system, both in adults and in kids. So that should be an exciting talk. And as usual, you can get CME for this, text your codes there, and that will be put into the chat function. And you can, thank you, Ingrid, we can unshare that screen. And moving forward, I am really so grateful to have Bonnie Maldonado join us today. And Bonnie, this is a really momentous day because on the one hand, we are surging like crazy. We had 3,000 plus deaths yesterday, which was a record. On the other hand, we have really exciting news on the vaccine front. And Dr. Maldonado really has been a key figure in many of those efforts and has been part of the FDA's EUA today and will be giving us some updates about that and other news related to the vaccine. Bonnie is the chief of infectious disease in pediatrics and is also the chair of the Red Book Committee for the Committee on Infectious Disease in the AAP. Is the associate dean here, wears so many hats and is really hard not to see in a local newspaper or a national newspaper when you read a story about COVID right now. Rajni Matthew, as I mentioned, is my partner in crime. Has really been fun co-chairing this with you, Rajni. Rajni has been the really figurehead behind all of our infection control efforts relating to the pandemic and other infections at Packard. And so really excited to have her here today. Dr. Maldonado is able to join us for the first half an hour and then has to get back to the FDA meeting. So we are going to take advantage of Dr. Maldonado's presence and focus today. The three areas that we are hoping to get into based on, we received a whole slew of questions from folks in the community. And we're trying to focus today really on vaccination, which is at the forefront of everybody's mind, but also the surge in general, how it's affecting children, how it's affecting our hospital. And then lastly, lots of questions about testing. So we're going to try to do immunization first and take advantage of Dr. Maldonado's presence for that. And then we'll focus on those later two issues after that. So Bonnie, it's been an interesting day, an exciting day. Can you tell us what you've learned from the front lines and what we have to be thankful and excited about?
Yeah, sure. Sorry, I don't know if I'm, it says the host is blocking my video, so I can't seem to turn my video back on. I don't know if you need me to, but I can speak in the dark.
Yeah, Ingrid, are you, are we able to be able to see Bonnie?
I just made her co-host.
Well, while she's working on that.
I can go ahead and tell you. So basically, what we do know is about this vaccine is that it's, well, first of all, there's two vaccines that are being reviewed right now by the FDA. One of them is the Pfizer vaccine, and the other one is the Moderna vaccine. And there you are. They're both mRNA vaccines, and they're really an interesting platform because we've never had an mRNA vaccine licensed for use before for any pathogen. They're basically small pieces of RNA. In this case, we'll hear more about the Moderna vaccine next week, but The Pfizer vaccine is basically a piece of modified RNA that codes for the spike protein on the surface of the virus. And it is wrapped in a lipid membrane that is engulfed by the host cell. And then that's unwrapped in the cell, and the mRNA does not seem to integrate into the cell genome itself, but it sits in the cytoplasm of the virus of the host cell, and then you see replication of RNA, and then you have protein production in the cell as well. And so what the protein that's produced you see is purely just spike protein. So it is apparently whole spike protein. And as we know, the spike protein is what is used to help in the attachment and the entry, cell entry of the virus into the human cell. So this is not a quote unquote live virus in the sense that it doesn't replicate live virus. It just causes replication of the spike protein in large quantities. So then that is released by the cell. And then the immune response is directed at that spike protein. So what we understand from the company and what they've shown in the laboratory and in some of this data that's they've published already is that you get this beautiful B cell response within 10 to 12 days after the first dose. And so we know that there's B cell responses, but there's also T cell responses. And they go down what's called the Th1 pathway, which really is focused more on antibody production. There's no evidence of inflammation, active inflammation in response to this, systemic inflammation in response to this antibody, to this vaccine. But the other thing that they've been able to demonstrate, the company has, and they published this as well, is that they develop individuals develop effectors T and B cells, but also memory T and B cells. So the idea is that there will be B cells and T cells that can be can be activated after vaccination if there's a pathogen present. So for example, if somebody's exposed. So you can see here that this slide really shows you after the first dose of vaccine, the blue line is people in the placebo arm and what their infection rates look like over time after vaccination. And you can see that, and the pink is people who got vaccine. And you can see that basically by 12 days, there's really very little to no increase in the number of cases in the vaccine group. So in total, out of 44,000 people who were vaccinated, there were 170 cases of symptomatic disease. So they didn't look for asymptomatic disease. I'll talk about that later if you like, but right, what they looked for was symptomatic disease. So PCR proven in symptomatic infection. And of those 170 cases, 162 were in the placebo group and 8 were in the vaccine group. The study was really only powered to look at that difference. But when you look at differences by age, comorbidities, severity, et cetera, those wasn't powered to statistically look at that. But in all cases, all the placebo recipients had the overwhelming number of cases compared to the vaccine recipients. So for example, for severe disease, there was only 1 vaccinee who had severe disease and 9 placebo recipients who had severe disease out of those 170. And that 1 severe vaccinee, basically, they met the criteria because they had an SpO2 of less than 93%, but never had to go to the hospital, where they were at home, and they actually did very well and got better pretty quickly. So it's really looking remarkable.
So not only highly effective and probably much more effective than we had anticipated and hoped at preventing transmission, but also effective at preventing severe disease is the takeaway from this data.
Yeah, it looks like it, although again, it's not statistically powered to do that, but because the numbers are pretty small, but they'll continue to follow that up over time. Yeah.
So talk us through, I mean, so what I'm seeing here is, up until about day 10, and obviously these are small sample sizes in the placebo arm, but it seems as if the lines are in conjunction with one another, and then at about day 10, we start seeing this break. So as we start to vaccinate folks, and we're not going to talk a ton about healthcare worker vaccination today because there's going to be a number of town halls. There just was one that you were on. But what does this mean as we get vaccinated in terms of how we can think about our own protection?
Yeah, so we have to be really careful about that. What this shows is that after your first dose, the efficacy after the first dose is 52%. So you really do need that second dose to really block full, up to the 90, potentially 95% level. But again, the company only studied symptomatic infection because remember, they're talking about 44,000 people. They enrolled them in less than 2 months, and they're following them continuously now. And so we only know that this is highly protective against symptomatic disease, but we don't know yet whether it's protective against asymptomatic infection, or asymptomatic disease. So for example, it's likely, although we don't know this for sure, that people can become infected even after they've been vaccinated, but they won't get sick. And so they could transmit to others, and that may not be the case. And so the company has actually committed to following that question up now that they can take a little bit of a breath and look back and study the overall other key points here. What they really wanted to prove first was efficacy. Now they can go back and say, can we actually prevent asymptomatic disease? Which would be really critical to know, obviously, because then that means you could potentially not wear a mask or you could not socially distance, but we cannot say that right now. So right now, vaccinees still need to distance and mask until we have that data. The company has also said that they would continue the study so that they could actually get full licensure, not just emergency use licensure approval, but actual licensure like any other vaccine by the middle of next year.
So that's efficacy, which is very encouraging. Tell us about safety.
Well, so safety is also very good news. So there are adverse effects, but these are really mild. So if you think about it, about 50% or more of individuals will have pain at the site of injection, and pain and swelling at the site of injection. So that'll be at least 50% of people, if not a few more. And that's actually going to happen more likely after the second dose than the first dose. And it will also be more common in people under 55 compared to those over 55. But you're going to see a lot of sore arms. But when it comes to other side effects, there are going to be smaller percentages of, for example, fever, and myalgias and headaches in a very small, like less than 5% of people who got vaccine compared to placebo. And all these serious side effects, there really are no signals that are different in the placebo and vaccine recipients.
Can you talk a little bit about the news coming from Britain about the two anaphylactic reactions?
Yeah, we haven't actually, the meeting's going on right now. I have to go back and replay. Luckily it's on YouTube, so I can go back and replay some of it, but they haven't really talked about that. We don't know what that means at this point, but those are anaphylactic reactions. From what I understood, it was 2 healthcare workers who had anaphylactic reactions.
Yeah.
And both of them had already been using adrenaline or epinephrine for other conditions. We don't know exactly what. So they're currently recommending that people don't get vaccinated if they have a history of allergic reactions. Now, that question hadn't come up yet on the webinar. So, but other effects, for example, have not been found. Now, I will say that there were 4 cases of Bell's palsy in the vaccinated group compared to the placebo group, but that didn't reach statistical significance. On the other hand, we know that Bell's palsy doesn't have a very high incidence, so we'll have to track. There will be lots and lots of post-vaccination surveillance going on as well.
Yeah, and no signal for allergic reactions, at least in the trial, although folks with a history of having anaphylactic reactions weren't included in the trial, but still encouraging that at least for folks who have not had a history of allergic reactions, that we didn't see any in out of the almost 90,000 people, or 45,000 people.
Mhm.
So what about kids? We know that we have not had much inclusion really at all of young children, and not much of even older children as well. I think the Pfizer one went down to 16. But what can we expect in terms of testing in kids, and how would that then translate into when we'd actually be ready to immunize them?
Well, you probably know that we drafted letters for the president of the Academy, American Academy of Pediatrics, and we wanted the HHS, Health and Human Services, to know that we really wanted to see vaccines trials in children as soon as it was safe to do so. And I think we thought that it was really prudent to see what the safety data looked like in adults. And as you know, there are already the Janssen vaccine, the AstraZeneca vaccine, the Pfizer vaccine, and have already started vaccinating kids as young as 12 years of age. In fact, in this study, of the first 30,000 people enrolled were older than 18, but of the subsequent 14,000 that were added on at the end, some of those had higher risk for comorbidities, and then there were also children, younger children as young as 12. So they've already started to vaccinate 12 to 15-year-olds. I think Moderna has said they will start, but they haven't said when. So we're drafting letter. We've already drafted letters saying from the Academy that we really want to see this. Then companies are going to start vaccinating in serious trials now, looking at younger children. And actually, exactly what I thought would happen is what was announced today, and that is that Pfizer plans to do bridging studies for the kids. So what that means is, rather than doing the full court press 44,000 people and looking at placebo versus vaccine and looking for symptomatic disease, they're not going to do it that way. They're going to do antibody studies, because if you think about it, children are less likely to be symptomatic, we think, than adults. So it would take many, many, many more children than 44,000 to be able to look at a signal for to look for symptomatic disease. So they're going to take the data from the current study and look at the antibody responses and see if they can come up with an antibody level that appears to be protective. Excuse me, sorry. And then they are going to do what we call a bridging study. So they'll look at the immunogenicity in children. This is what they did with the HPV vaccine, by the way. They demonstrated in the HPV vaccine that in women 20 to 26 years of age, there was antibody that was deemed to be protective against carcinoma in situ. And then they use that antibody level as an outcome for children. And what they found in 9 to 12-year-old children is that they actually had way better immune responses than the 20 to 26-year-old women. So they were able to get approval for the HPV vaccine in 9 to 12-year-old kids. And so following up over the years, now we've seen that has borne out. So the same thing will be done here. These will be immunogenicity trials, and it'll probably be 3,000 to 5,000 children is what I understand for this vaccine, and probably the others as well. And then they'll see if antibody responses are at least as good as in adults as a way to look at translation into vaccinating kids. And obviously safety will be a major concern and a part of the trials as well.
Yeah, and on that, we've discussed before the entity of MISC and it being potentially an immune-induced response. Some have worried a little bit about the possibility that the vaccine might induce that. Has that evolved in your thinking at all? Is that like something we should worry about, or is it just time will tell?
Well, I think so. First of all, that there have been about 2,000 cases of MISC, and Rashi can tell you later. We actually had a case here at Stanford just recently. We've had a few overall, but it is pretty rare. So to try to look for MISC as an outcome is just not going to be able to happen with a rollout of a vaccine. But the immune correlates of MISC at this point so far are not looking like they are being triggered, for example, by the vaccine itself. So the vaccine looks like it's not, it's not going down a pathway that would respond, elicit highly inflammatory responses after vaccination. And we haven't seen that in the people who've gotten infected after, for example, after being exposed to natural or wild type virus. We have not seen that kind of a response. Now, granted, the numbers are small so far, but it doesn't appear that the concerns, at least from the immunologic standpoint so far, or the actual clinical experience in the patients who've gotten sick, that will bear out, but it certainly bears further follow-up of the kids. And so there will be obviously immunologic studies that people are doing here at Stanford and elsewhere, looking at this phenomenon of MISC and how is it really, what is the nature of it, and will vaccines play a role in that? So far, it doesn't appear so.
We had a whole bunch of questions submitted, looking, asking about sort of subpopulations within kids. A lot of people wondering about kids with medical complexity, perhaps chronic lung disease, or even immune deficiencies. And so obviously really early to speculate on that, but just can you see there being sort of universal vaccination of children, or are we going to be concerned about subgroups? And also people interested in knowing about pregnant moms as well.
Yeah. So the data from the Pfizer trial was helpful around that because they did go out of their way. About 40% of the people enrolled in the trials actually had comorbid conditions, which is pretty amazing. And they did not, now the study wasn't powered to look at comorbidity, but they were able to demonstrate that across comorbidities, there were still an equal distribution of cases by comorbidity. So there was no signal that vaccination was a contraindication in those populations, which is a good thing. And so the question will be what happens with children. And I think if the data play out similarly, they probably will see that comorbidities will be not a contraindication to vaccination. And we are seeing obviously that the data is starting to stack up, that comorbid conditions are obviously a risk for adults for sure. And then for children, it appears that that may be happening as well. So I do think that this could be a universal approach. Now, the one question that remains to be answered, and the company hasn't gone there yet, and we'll see what happens, is immunodeficiencies. That is, and their concern was only that they didn't know whether they might need a higher dose of this. It's 30 micrograms of the product. And whether or not, because of immune deficient kids or adults may not be able to mount a good response, whether that's a sufficient dose or not. And I can imagine that those would be trials that could be done as well in the coming year or so. And so that would be the only concern at this point, although there might be others. Now, this issue of, some people have brought up this issue of integration of mRNA, and it really doesn't look like that's been the case. It's really isolated mRNAs, and these, the idea that it would, you could have integration, as a complementary DNA strand, for example, that hasn't really borne out so far.
Already a number of questions have popped up on the chat I want to get to, but before we do that,
sorry, do you want me to talk about the pregnant women?
Oh, yes, sorry, please.
About that. Yeah, so basically the answer is, unfortunately, CDC hasn't weighed in one way or the other. And Yasser El-Sayed has been highly involved with the ACOG response. So ACOG is planning on putting out some guidance for pregnant women. And right now, what we are probably going to recommend until we hear guidance is that, and Yasser, I think, is okay with me saying this, that he indicated that that the idea would be, because many, obviously, healthcare workers will be pregnant. And so the idea would be that they would talk to their provider, and would have to be a case-by-case basis. And then they would, if they agree, they would be vaccinated. If they don't agree, then, they don't have, this is not a mandatory vaccination, but the ACOG needs to weigh in at some point. That wasn't brought up yet on this, obviously at this point that didn't happen. But for breastfeeding women, that's going to be a bigger proportion of people as well. There are no data suggesting that breastfeeding is at risk. So CDC, again, has not weighed in. I hope they will vote soon, because I do think that many of us did state that we thought breastfeeding should not be a contraindication to vaccination. But again, ACOG will be weighing in on that as well.
Great, well, thank you. I want to be respectful of your time. I want to get to these questions, but a really important concern right now is vaccine hesitancy. And I think, as we think about kids, particularly since the burden of disease in kids has not been as great as it has been in adults, one can envision certainly even more vaccine hesitancy when it comes to parents of children. So what are your thoughts on that? How I know we've seen some evolution now where the public's perceptions are more favorable than they were before we had all this encouraging data. But what are your concerns? What are you expecting?
It's hard to know. I've been on the Red Book Committee since 2010, and we go to ACIP and we get a lot of hesitant people, but these are the people who actually fly to CDC to come and see us they really hate us. I mean, it's really discouraging, unfortunately, to see that people are looking for answers, and I don't blame them for being frustrated, but somehow they are being misdirected to a product that has been demonstrated over and over to be safe. So somehow we need to address. Right now, we have an opportunity to catch those people who are questioning, who aren't really hardened and angry and have been, are in this very small group of people who are just really angry and have been caught up in this movement. And there's a lot of questioning. I mean, I questioned the vaccine over the summer. I said, I want to know more. We wrote letters all over the place about we need data. We need to be transparent. And I mean, everybody's responded properly. So our job across the board is to make sure that we get that message out to our constituents. And I have to say, they had an hour of public comment on the meeting today. And it is really amazing to see people who say, look, this is they pick random people out of the people who submit for public comments. And there were just so many basic community-based groups who said, we really think this is great transparency, but engage with us. Make sure we understand. Make sure you speak our language. Make sure you come to talk to us. I was on a town hall last night with the Southern California chapter of the AAP, and we were talking to providers, 500 people. So that's the front line. That's the provider, and people still trust their providers. So, and one guy who said, I don't turn away hesitant families. I just try to help give them information. And so I think it's just all about how do we communicate with people and get to those families who are going to be neglected or who don't speak English or who, aren't engaged otherwise. So I do think it's going to be important to vaccinate kids. They do get infected, they can transmit. And I think if we want to get back to school, I mean, I wish we could do that now. We should be, if people have resources, we should be encouraging families and kids to go back to school. I think there's just a lot of fear about what would happen. And I think vaccinating the kids will keep them healthy, but will keep their teachers healthy and the staff. And it also just reduces the herd immunity. It increases the herd immunity, I mean.
Also important to get teachers vaccinated, of course, as soon as we can. So a couple quick questions, maybe we can just do these, a minute each or something. That first is about an interesting question about the relatively short follow-up period from these vaccine trials. How can we be confident that will last? Will we be getting vaccinated every year?
So I'll tell you, Pfizer this is what they do for a living, right? They've been producing vaccines for a long time. And I know the people who work there, they presented today. I have to disclose I'm on a DSMB for a Pfizer vaccine, but so I don't work for them, but I'm on an independent monitoring board. They work with the highest integrity. These are people that I trained with in fellowship and who I've worked with over the years as an academic and so I think these companies really need to have the highest standards, but I do think that they actually today presented a rationale. They said, look, we're in the middle of a pandemic. We're building the airplane as we are flying it. As I know that's a tired kind of analogy at this point now, metaphor, but it's true. So they need to get something out that is as safe as it can be right now. And they promised a median follow-up of 2 months. And that's what the minimum required is for most vaccines is a 42-day window after vaccination of safety. So they added on to that a few days just to give some wiggle room. But the idea really is that they have guaranteed that they will get at least 6 months of follow-up on safety data. and they will complete the 2-year follow-up of their vaccine trial. What's really interesting, and I won't spend too much time there, is the ethical dilemma of what happens after, the next 6 months or so when we see all this safety data. Will it actually be ethical to enroll any more people in placebo-controlled vaccine trials? And they've actually addressed that up front. So there may be, for example, a double-blind, a crossover trial where people can be crossed over to the other arm, and then you can still follow them for safety and efficacy.
I think Steve Goodman gave a talk about that today, I believe.
Yeah, you did a really nice job. Yeah.
Yeah. So the second question, in terms of thinking about giving this vaccine in conjunction with other vaccines such as flu, or in kids, obviously a whole bunch of other vaccines, any thoughts about that?
It hasn't been done yet, so we'll just have to see. We're used to doing that, and as you know, sometimes it's fine. We have combination vaccines all the time. It's usually okay, but as you know, with MMRV, there were some increased febrile reactions, et cetera. So it's possible. Again, mRNA vaccine platforms have never been licensed before, but we'll just have to see what happens. But my view is that I'm not super confident that this will be durable, long-lasting immunity, just because that's what happens with the other coronaviruses, the normal seasonal coronaviruses. You can be reinfected. So the question will be just to see how durable that immunity is, and if it's, if we need to give a booster dose on a regular basis. That's the other thing about the mRNA vaccines. Apparently, they're much easier to give boosters for. You can boost them over and over, and because they're just mRNA. So. We'll see whether there's any increased risk for reactions after boosting, but it's all unknown at this time.
Last question, I think this followed the discussion about high-risk groups for immunization. Any data on using monoclonal antibodies for prophylaxis?
Yeah, that's a mess right now. We're doing a bunch of trials right now on our outpatient side. We're doing the Eli Lilly trial, the bamlanivimab trial, and that's a mess because we got EUA for it, but it's still not approved, fully approved. So it's really highly restricted. And I do think that there's a place, there could be a place for monoclones, because if you think about this vaccine, the idea that you're developing antibodies to the spike protein and getting this high efficacy, the monoclones should probably work. And I think they may be getting a bad rap because the trials the EUA was given too soon before we really had a good chance to get enough data. Again, I think people are just worried about not having anything to give hospitalized patients. So we know that they are actually contraindicated in people who are on ventilators, and I'm not quite sure if that's just because the numbers were so small, or those people would have done poorly anyway. But there is actually, we're doing a great trial. We just started this week on prophylaxis with monoclones, and that'll be really interesting because if you can't get enough vaccine in certain places, perhaps you could give an injection of a prophylactic monoclone product, and so there's going to be those coming up as well.
Dr. Maldonado, as usual, very enlightening and informative, and we thank you for everything that you do and for contributing to the national discussion today. Thank you so much.
Yeah, thanks a lot, and I look forward to talking to Roshni afterwards. Sorry, I got to jump off, but happy to talk with you, and happy to take questions offline from you as you get them.
Great, thank you so much.
Thank you, Bonnie.
Take care. Thank you.
And we will, to Bonnie's note, we will be trying to post on our website all of the questions that were asked, and for those that we weren't able to get to, we will try to answer online. Rajni, we're in the midst of the worst surge yet, seeing cases at the Stanford Hospital, at least at record numbers. Can you talk us through what we're seeing, what it means for Packard, what's going on?
So the numbers are at the highest they have been. If you remember, in July and August, we did go through a spike as well. We are seeing a similar trend right now with high numbers. At Lucille Packard, again, we are lucky that children don't get so sick, and many of our positives are still asymptomatic positives. So they came in for a completely different reason. And as part of our pre-admission testing, we found them to be positive. So that's typically the trend. Our children's hospital has maternity unit, and so we do see the trend in maternity patients as well. And so that gives us a signal. And so we are hovering in the numbers that we were in July, I would say.
It's always been tricky because hospitalization numbers that are reported nationally are just simply kids that are hospitalized that test positive. And at least our local experience has been that most of those have not had real symptomatic COVID infections. Do we have a sense for whether that's true nationally too?
Yeah, in general, that has been the trend, that children, even if they get infected, have been mildly symptomatic or asymptomatic. Hospitalizations have always been lower, and that trend, I believe, has continued through and through. So we still experience the same thing. We had a few patients that had moderate to severe disease that were admitted during the previous surge that we experienced. So I do think that a similar trend would continue even now.
And a comment on any MIS-C cases?
Yeah, we have seen a few. Some MIS-C is kind of tricky, as you can imagine. It has to have several features, and some are on the milder spectrum. Some are fairly clear-cut. So we've had a few instances of MIS-C, and they have all done well.
Yeah, that was my experience as well. So now we have more restrictions on activity and school. A lot of questions submitted about schools and daycare and safety and you know, the schools that were open are being allowed to stay open, but schools that have not been open yet, now we're looking at, you know, March or even later. Can you comment a little bit about what we know about transmission, how that has evolved, and any opinions you care to voice about schools and daycare for that matter?
Yeah, so I think in the beginning it was unclear. I think in the beginning when the pandemic started, there was the sense that children are probably going to be a very important part of transmission because that's what children always do. But I think as the months have gone by, it is clear that luckily, children seem to be somewhat less susceptible to getting infected. And even when they get infected, they have mild disease. And even when they have, and when we look at transmission risk, there's data on both sides. There have been studies that have shown that children are not contributing. Then there have been studies that have shown that children can transmit. But overall, the risk of transmission from children is considered to be lower. So all in all, I think we have more and more information that if you weigh the risks and the benefits, it appears that children going back to school is the answer. However, the schools have to be prepared to or resourced to be able to do this safely. So we still have to follow all those precautions, and those are not necessarily easy in a non-healthcare kind of situation, and to expect children to wear a mask, and for non-healthcare personnel to understand many of the things that are very obvious to people like us who are always in the middle of infectious issues. So I feel like those are the challenges. But I do think that we have enough information to keep the schools open safely.
So schools that are doing it well, to summarize, schools that are doing it well and following recommendations seem to have an exceedingly low transmission rate.
Yes.
And then, but daycare is hard to get young toddlers and of course infants to wear a mask. What about that? I mean, some of my colleagues, of course, have to go to work, have to either have a nanny or daycare, and not everybody can afford a nanny, of course. So, what about daycare?
Yeah, so far this similar thoughts on daycare as well. There have been some studies that have, some experiences from daycare transmission that again appear to be an index of a staff member, but then we know that those children went on to infect their parents, for example, and siblings. So young children cannot wear a mask, and that's where we lose the source control part of it, but then there is the opportunity to do all other mitigation. So the caregivers have to be masked, and even when they're not with the children and they're having meals, for example, they need to follow precautions. So there are all of those other additional measures that can be followed even in those instances when the child cannot wear a mask.
Yeah, important for the hospital setting too, where we oftentimes gather in small workrooms.
Yeah.
So
yeah, that's been the experience for healthcare personnel and positive results as well. That's not just in the hospital setting, but outside of the hospital and social gatherings resulting in infections.
Yeah, I think the good news is that most of the transmission we've seen within the hospital, at least, has been in situations where sort of adherence to recommendations has been suboptimal. But by and large, we've managed to keep people pretty safe, and the evidence for in-hospital transmission continues to be very, very low. Is that fair?
That is fair. And that's exactly why we feel safe with the PPE guidance. I think in the beginning, there was all these concerns about not knowing exactly the mode of transmission, but I think over the last several months, we've continued to solidify what we originally hypothesized, that this is a droplet transmissible organism. We have to take specific precautions when you're doing aerosol generating procedures, but otherwise, general measures should keep us safe. So I think all of that has panned out over the last several months.
Couple, we've mentioned several times today that kids tend not to get very sick. A couple questions submitted in advance were concerned about long-term effects of the virus. There's of course all sorts of concerns about long-term effects of the pandemic and screen time and everything else. But in terms of the long-term effects of the virus, we've had a whole session on COVID in the heart. That recording is available. We're having a session in January on COVID and the nervous system. But the long haulers is a term that's been applied to folks with persistent symptoms in the adult world. Any comment or experience with sort of persistent symptoms in kids at this point, and the extent to which that should be factored into how vigilant we should be about protecting our children from this virus?
Yeah, it's a good question, and a lot of anecdotal experiences on this entity called long COVID, and mostly in the media and social media and other news networks. There is not a systematic way in which this has been looked at, but persistent symptoms following a viral infection is not a new entity. For example, in our outpatient pediatric clinic, the ID clinic, we see patients who have had Epstein-Barr virus, for example, and continue to have symptoms long after the acute infection is done and over. This is primarily more so in older adolescents. And so in young children, we've typically not seen that. And again, hard to know if this is just because we just don't know, but I have not heard of similar long COVID issues with young children. However, in adults, there have been a few reports, like early on, CDC had published looking back at over 200 outpatients. So these are patients who had mild disease that never got them into the hospital, and they did like a 2 to 3 week follow up on them, and 1/3 of them had persistent symptoms, and and there were a substantial number of them who had comorbidities. Then there's another study that came out of Italy, which looked at hospitalized patients, and they had a 2-month follow-up on them. They found that a substantial number of them had persistent symptoms. And these persistent symptoms are not fever or respiratory symptoms, but they are mostly fatigue and other non-specific symptoms. So just like I am going back to our pediatric ID clinic patients that come to us, if you do their laboratories, they are all completely normal. So if you check the inflammatory status and all of that, but they clearly have symptoms that are ongoing. Difficulty with attending school and difficulty with concentration. So these are real symptoms. However, we don't understand the mechanism of it, and thus we don't know how to manage it either. So, but this has not been systematically looked at for COVID in children specifically. And I would imagine it's really hard, just given the fact that thankfully we don't have such severe illness in children to start with.
Well, that and of course, so much overlap between all of these symptoms and symptoms that may just be from the stress of the pandemic and
Right.
not going to school and everything else, which is a real challenge. Some sort of nuts and bolts questions. And I know on the inpatient side, you get asked, including by my team this week, about sort of how long people need to stay in isolation after a positive test. And one of the questions, a couple of questions submitted about school, if you've been sick, if you've been positive, when can you go back to school? What are the latest recommendations on that?
So the recommendations, this is from now a little while ago, but that still is true today, is that if you have mild to moderate illness, you're an outpatient, the CDC recommends that you should be isolated for 10 days after onset of symptoms. That's because although the person can be RNA positive, they have not been able to culture viable virus from patients after like day 8 of symptom onset. In fact, the highest infectiousness is probably about day 2 to 3 of illness. After that, it consistently drops your ability to infect other people. So the duration of 10 days is true for most patients who are outpatient. For immunocompromised patients, that duration becomes 20 days. So that's pretty much what the CDC has recommended. Of course, 10 and 20 days is also contingent, again, on being afebrile, reduced symptoms and all of that. So those still are important.
Well, we're going to move into testing now, but let's build on your answer there. Why not use testing to shorten the quarantine period or the post-infectious stay-at-home period?
So the problem with testing is, and we did this in the beginning of the pandemic when we actually tested healthcare workers before they could come back into the hospital. And that really did not help us, because many of these healthcare workers were completely asymptomatic, but had to stay at home because they would shed for weeks on end. And it was not a good use of anyone's time or resource. So that would hold good for many of we have experienced this for our patients as well, where they have been retested and they are still positive. So this has been an experiential, for us, it has helped inform our decision to not test them, but to use guidance from, this is true about other viral illnesses as well, like influenza. You test to make a diagnosis. You don't then test them again to clear them to go back to school.
I suppose you could argue, though, that one testing strategy might be if you retest them and they're positive, you ignore it. But if they're negative, you pay attention to it.
To reduce the duration of isolation.
Yeah, and get kids back to school in the case of this question.
Right. And that's a good question for the outpatient world, especially if you've picked them randomly as a positive and you're not sure. It might be from a month ago that somebody else was positive and this child had gotten sick at that time. There are strategies to use that in the outpatient world, I can imagine.
Well, so let's stay on testing and tons of questions about testing. As you saw in Medical Grand Rounds yesterday morning, everybody who submitted questions is frustrated about testing and some of the delays, which of course largely are just due to the massive volumes right now. But can you talk about the state of testing at Stanford Children's, for pediatricians that want to get their patients tested? How do they do it? What are we using? Get us up to speed on that.
Yeah, so the testing, just to go briefly, there's still those three strategies. The nucleic acid the PCR testing is like the most common strategy that is used. There are antigen tests that are available, and then there is the serology testing. The most commonly used strategy is the PCR testing, and that's what we're using at Stanford Laboratory primarily. Um, the reason is it is highly sensitive, and so it has a far lower false negative result. So in a hospital setting, that becomes very important to detect all positives, and the risk for missing a false negative and the consequences of that are high. So PCR testing, it obviously depends on the volume. So we have had a massive increase in the requests for testing. And so that obviously the lab has some backlog because of that. But then we have to also remember that there are issues with reagent supply and all of that that impacts the turnaround time as well. The antigen testing, these are the quicker turnaround tests. There is actually an interim guidance on antigen testing from CDC from this week. And so I would refer you to that as well. And it is a nicely written guidance about when to use it. And basically antigen testing can be relied on for symptomatic patients. So for example, a child that is mildly sick with runny nose and congestion that now cannot attend daycare, in those instances, the antigen testing could prove to be quite useful to help detect a positive test, because then you can rely on it. Antigen tests do have an issue with sensitivity if you're asymptomatic, so then it becomes less reliable. Serology testing is to detect your immune response if you've had the illness before, and we do use it in our clinical practice for patients like with MISC who are negative for SARS-CoV-2 by RNA, but you're very strongly suspicious of MISC, you could do serology testing. So there is utility in that testing as well.
And so the antigen testing, so when we talk about home kits for testing, that would be antigen testing?
Yeah, that would be an antigen test. I don't know if there is a home test yet, but that would be the test that would be used.
So, given what you just said about the concerns over the low sensitivity of that, I think many people are seeing those tests, particularly if results are immediately available or half an hour or whatever, as being kind of one way to liberalize activity. But sounds like if false negatives are a big concern, maybe that wouldn't be so wise.
Right. And so I know that you had asked me this question about can there be a test that you can do and then meet for dinner with other households? I think the issue with that is the false negative problem. And of course, the test today is not going to be the test result tomorrow. So it's all that moment in time that you're doing the test. So those are the issues with this infection.
Yeah, so certainly, the idea of testing today so you can hang out with someone in a couple days makes no sense. If a test was reliable and it was to do an activity in real time, that to me would make some sense. But if the sensitivity is really suboptimal, then that obviously detracts from that plan as well. I don't think you mentioned that lots of concerns about sticking a small probe all the way into the back of a little kid's nose. I've had it done several times and I didn't like it. I can't imagine the distaste that a 6-year-old would experience. Can you talk about what we know in terms of nasopharyngeal versus mid-nasal versus anterior nares? And I know there's even been some saliva or oropharyngeal tests. So where are we moving in that direction?
So yes, in the beginning it was, we strongly felt like NP is the gold standard, you should stick with that. And we still do that for very specific patient population, like for inpatient admissions or preoperative patients. that is still considered to be the most optimal site for sample collection. However, more and more that we are feeling comfortable, especially with patients who are going to be in the outpatient world, that we can use mid-turbinate sample site. And anterior nares is another one that actually Bonnie's study had looked at and showed. So the sensitivity is lower, but it's not very low. So there could be applications of that in in settings where the impact of getting a false negative is not that high. Saliva, I mean, I was just reviewing for this, and it looks like it is promising, especially in the beginning of the illness when the viral loads are high. The sensitivity of saliva testing compared to NP seem to be quite equivalent. But I believe the swabs are different, and we have not rolled something like that out here at Stanford yet.
So at Packard, we're still using the nasopharyngeal
for inpatient admissions, but our ambulatory testing sites can do mid-turbinate for patients who are going to remain outpatient.
Okay. Okay, and as far as turnaround is going right now, do you have a great sense for that?
Yeah, there has been some issues with turnaround. Usually, as you know, we used to get results within 24 hours for routine cases. We do have especially rationed the rapid testing and all of that for time-sensitive results in the hospital setting. But for outpatients, I believe there has been some increased turnaround times because of the huge volumes in the laboratory right now.
Which might put lots of questions about why we're not doing routine periodic screening of healthcare workers. Other centers are doing that. We're seeing some schools doing that. And do you have some sense for why Stanford has not adopted that approach?
Yeah, so we have talked about this multiple times, right, from the start of the pandemic, when the state and county had recommended that healthcare workers should be screened in at some cadence. The issues obviously is that we are talking about tens of thousands of tests and diversion of our resources, laboratory and personnel to test a population that we know have always had very low positivity rate. The other side to testing at such massive scale is the false positive results, and dealing with false positives. Every test has false positives. So the lower the pretest probability, the higher those problems. And so we have consistently decided that we have a very liberal policy around testing. So anyone with the littlest of symptoms can get tested. Anytime there is an exposure or concern for exposure, you get tested. So there is a lot of availability of testing. It's just, it did not seem that it was worth the resources to do this on a large scale on a regular basis. But these things can change continually, and it is dependent on the mandates and mandates versus recommendations that come from the county and the state.
So someone just put Arun, I'm not sure which Arun that is, but mentioned that Stanford physicians and employees are likely to go to weekly surveillance testing soon via the Color home testing kits. That's not like a pregnancy test where you get the result now. It's where you do it at home and send it in and get a result.
That is correct.
What do we know about that, the reliability of that test?
I don't know the reliability of that test. I believe it's a PCR as well, so it should be fairly high. And the exact process by which that's going to happen is yet to be determined, but it is true that a notification about that has come out to all of us.
And several other comments bemoaning the recent turnaround time, and I guess all we can really say about that is people are working on it. We heard yesterday that once the samples were being received, the turnaround time was still less than 24 hours, but I'm not sure that that's for Stanford labs, and I'm not sure that that's really gelling with what people's clinical experiences are. So we'll see how that pans out. Obviously, we got to get the pandemic under control, I think, first. There's guys, and by the way, for people, we'll go a few minutes over. Put your questions in the Q&A. A lot are coming into the chat, but so when someone asks, does the PCR test have maybe they need to say, why does it have a high false positive rate? It's just because it's very highly sensitive, right?
Oh, yeah. False positive in the sense, persistently shedding individuals will have a positive test. It is highly sensitive.
Yeah. Another question about, I think this had to do with the comment about isolating for 10 days versus 20 days, or 20 days if you're immunocompromised. Someone asked if the family member of a COVID positive patient is immunocompromised, should the COVID positive patient self-isolate for 20 days instead of 10? But it really has to do more with prolonged shedding of virus, right?
Right, it has to do with the host. So the duration of isolation would be the same. The thing with the COVID positive household member, there is a period of quarantine that the rest of the household would have to do as well. And that is typically been 14 days. So if you've heard 14 days before, that's the duration of time a household contact of a COVID positive person would have to quarantine themselves. That duration of quarantine, CDC has very recently reduced to 10 or 7 if you can test negative. So that is yet to come into our workflows, but that is a new guidance from CDC.
I want to make sure I get this question because it sounds like this is an issue that pediatricians are dealing with not uncommonly, but I think in part particularly because of some of the testing delays, some pediatricians are being asked to clear kids who might be mildly symptomatic with probably a viral upper respiratory infection, to clear them to go back to school. Do you have a sense for the wiseness of that, of that strategy?
Yeah, I know, and I know who submitted the question as well. It's a very tricky situation where it's impossible for a pediatrician to say somehow that a runny nose or a congestion is not due to COVID, and so you can return to school without doing a test. And so I think the issue is getting a person tested is a big procedure. And so that further delays that child from going to school. And that's where I think there is a role for antigen testing. If a patient is symptomatic, I do think that would give the pediatrician an additional way in which to help reassure themselves, the family, and the school that they have evaluated the child and have a negative test. And so I feel like there is a role for antigen testing in those scenarios.
Yeah, I mean, of course, the transmission of other viruses right now is still very, very low. Maybe we can close with a quick comment on that. We're seeing a little bit of rhinovirus, I believe, but we still aren't seeing really any of the other winter viruses right now. Is that correct?
Yeah, that is correct, and goes to tell you that that's because of all the precautions that we are taking. And Alan, you had shared that Australian or New Zealand, I cannot remember, where they had the increase in RSV the moment they reduced their precautions and stay at home and all of that. So I do think that those, yep.
Yeah, this is really interesting actually, because in their winter, which is our summer, they really had no RSV whatsoever, and now we tend not to see RSV in the summer, but they are seeing really a huge RSV surge right now, which is fascinating. So suggests that perhaps we will have a bronchiolitis summer instead of a bronchiolitis winter.
Yeah. It'll be interesting to see. I don't understand that very well at all, but yeah.
But to conclude on, assuming that when a child has infectious symptoms right now, that it is COVID until proven otherwise is probably a wise strategy.
Yep, I would say that. Mm-hmm.
Yeah, I hear a number of people say, well, they only had a cold, so it probably wasn't COVID. But of course, we can't say that. So,
Mm-mm.
all right. Well, thank you everybody for joining us today. Again, we will try to post any answers to questions that we weren't able to address, but I think we got almost all of them. We appreciate all of your questions, and we will see you in early January. Thank you, Rajni, so much for all of your input.
Of course, thank you, Alan.
Thank you to Ingrid and Allison too, and happy holidays to everybody.
Yeah.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.